Today's episode is packed with energy and inspiration. Thanks to our guest, Dr. Kaylee Dayton. Kali is a passionate critical care nurse practitioner, ICU consultant, and the voice behind the Walking Home from the ICU podcast. She's on a bold mission to reimagine ICU care, championing awake and walking ICUs and moving us away from outdated, sedation-heavy routines. In our chat, Kaylee opens up about her journey from traditional ICU settings to leading the charge for early mobility, better patient outcomes, and happier healthcare teams. Get ready for stories, real talk about financial and emotional impacts, and practical ideas on how smarter ICU practices can change lives, both for patients and for staff. If you've ever been curious about what's possible when we rethink the way we care for our sickest patients, or if you're looking for motivation to create change in your own corner of healthcare, you're in the right place. Let's jump in and welcome Dr. Kaylee Dayton to the conversation. Welcome back to Uncharted Narratives. If you're just joining us, we're continuing our second part conversation. Now let's continue our journey and uncover more remarkable stories and insights.
Delirium increases cost by 39%. 75% of falls in the ICU happen in the setting of delirium. Drastically increases length of stay by 4.47 days in the ICU, 6.67 days in the hospital. It's a huge contributor to needing skilled nursing or long-term acute care after the hospital. And it's largely preventable. There are lots of circumstances and risk factors for delirium, but in the ICU, we are giving deliriogenic medications. We are creating delirium factories that destine patients to have delirium and increases the severity and the duration of delirium, which all contribute to the overall costs, readmissions, loss of careers. So now you've got a lot of people permanently disabled that fall into the burden of the government to take care of. And a lot of this is very, very preventable. In the ICU, we're not even really adequately and properly screening for delirium. A recent study showed that across the country, I think it was like 140 some odd ICUs that they assessed, only 52% of them were actually screening for delirium. So even in the United States, they're charting delirium. They're charting on these assessments. But I can tell you from what I've been seeing, they're not actually doing the delirium screening. And many nurses, especially those that came in during COVID, bless their hearts, they were just thrown into the fire. They did not get adequate training and education, and there's no accountability in these ICUs. So we're not screening for acute brain failure that doubles the risk of dying and increased cost by 39%. And we have a process of care that destines patients to have delirium. That is extremely burdensome to the entire system. In addition, when patients are sedated in these medically induced comas, that drastically increases the risks of ICU-acquired weakness. Patients can lose up to 40% of their muscle strength within 10 days in the ICU. And yet that increases cost by 30.5% in the hospital and absolutely sets patients up for long, expensive rehabilitation admissions to, again, rehab, SNFs, LTACs, whatever facility. Oftentimes that could have been preventable if we had fought to preserve their cognition and their muscles during critical illness. But right now, most ICUs are not practicing the evidence to give patients the best chance to walk out of there and go back to their lives.
Well said. And also, I want to echo what you have said. A lot of number and statistic. It's very excitement and lovely to be implemented and take this risk to see how it will go with the hospital. And my network, they been between Arab countries and NAB. So I would recommend my country like Jordan, Saudi, Gulf country. Please try to listen for Kelly, connect with her, give it a try. She is driven by purpose and she have that ethics. She want to advocate for this. And I know Kelly for sure. She is very supportive and try to do this from her bottom of heart in order to support the patient. So there's a lot of return of investment if you consider that. And why not? I know, Kelly, you have now community, you create a community, and whenever you travel, they are following you, and you build this also through the podcast and the training you have done for them. So tell me about the training and how you train the staff and how you build this community.
I mean, each ICU has different needs, different barriers, different dynamics. And so I try to understand what's going on. I meet with leaders of each department. I want to understand from respiratory therapists where they're at, what are their staffing ratios like, what are their barriers, what do they understand? Same with physical and occupational therapists, nurses, physicians, APPs. So I try to get a sense of what's going on. I have them provide for me examples. Sometimes I visit the ICUs beforehand, but even if they just send me medical records, I can understand how they're treating patients and where their gaps are. And then I create customized webinars for these teams, and I do them live. And the tricky part is they need to be mandated. Every single member of the team needs to listen to these presentations because it is essential to build a foundation of why. If they do not understand the risks and the harm of their current practices, they will never be willing to change. And they also need to have this knowledge in order to critically think through each individual patient as a team. I wish we could create the perfect conveyor belt, the process of care and decision-making that works for every single patient, but that's not the reality of the ICU. So in these 4 webinars, we lay a foundation of why delirium is so dangerous, how to prevent and treat it, why ICU-acquired weakness is so lethal, how to prevent and treat it, and then a lot about the logistics, what it takes to create this. I bring in people from other disciplines, other teams, so they can hear from a respiratory therapist from another team talking about what it was like for them to make these changes. So sometimes I bring in people that I've trained in the past. So they can say, I know how scary this is. I know how incredible this sounds. I felt the same way. I was doubtful, but here's how we did it. And here's how much it's impacted my career, how much joy it's brought me, how much better my patients do. So that's really just getting people to buy into this concept, be open to it, and understand why we're working on this. So that shortly after that, I can come with a team. I bring a respiratory therapist and a physical or occupational therapist on site. We go to that ICU. And depending on the size of the ICU, we stay for a few days. We participate in rounds with the team and weigh in on the plan of care for their current patients to guide them and help them apply the principles from the webinars, how to master the bundle for their current patients. We can go to the doorway of the rooms, kind of coach people through. And so while we're there in person, they can start to see success. They can start to get patients up, awake, and moving that they never would have dared try to do before. And they can drastically see impacts to outcomes. We get people extubated. We have them walking around the hall sometimes. It is really fun to watch the team have light bulbs go off to say, wow, this actually works for my patients. And this patient would not have been like that. And this wasn't so scary. This wasn't so hard. So they get to see that for themselves. And then we also do simulation training 3 times a day. These are 2-hour sessions. And we go through their own case studies again. Someone is pretending to be the patient. And we're helping everyone collaboratively, critically think through applying the bundle for those patient scenarios. And then we can say, okay, so you had this patient awake and walking day 1, extubated day 2 or 3, but in reality, this was your patient. They weren't extubated until day 10. Do you remember this patient? Do you think it was easy to take care of this patient? Why were they confused? Why were they so hard to move? Because we sedated them. How would you prefer to take care of most of your patients? And by then, they're like, oh, yeah, the way we did here in simulation training, it's so much easier to get them awake, riding, moving day 1 rather than day 10. And so they start to see what's in it for them. They start to talk to each other and make plans on how they're going to collaborate, what they need from each other. We don't have group trainings. PTs never get to train with respiratory therapists. Nurses don't really sit there and train with physicians. And that is the time when we figure out as a team, how are we going to carry this load together so that they catch the vision of what this is actually going to mean for their team. Then we follow up remotely or through tele the next few weeks and over the months, have check-ins, help them make gradual goals. And so the first 3 months are pretty tough. They're growing pains. It's uncomfortable. They're really starting to do new things that they've never done before, but at least they're willing to and they're prepared to. They at least have some knowledge and tools and know how to do it. Whereas historically, if a hospital wants to do this initiative, they say, just do it and assume that their clinicians know how. But now they actually know how. By 6 months, there's a lot of momentum going. Everything's starting to get easier, quicker. Patients are getting off the ventilator, out of the ICU easier, and they're feeling it. They're getting it. By a year, they don't really remember what they were doing before.
Yeah, the old man. So you mentioned here very important point. You started with what, with why. So if they know why and they understand why and believe in the why, this is will make your work it's easier and they can implement and adapt this solution. And what I understand from you, if correct me, this is to implement your education and execute the bundles. It take about 6 months average in order to be fully implemented and trained.
So, when I start working with a team, it's until I physically leave the hospital, it's about 4 months, but then I continue to follow up after that. So yeah, but it takes about 6 months after I leave, after the simulation training, for them
So
to really get going.
there's a lot of activities there during the training, and one of the something we have discussed in the past, and I like the way how you teach your student the having scenario based, so you go through the scenarios, how technology can help you to implement those scenarios. For example, like what we started to see, the simulation lab, to have it, or not necessarily to have a lab, or something like you to have the AI to give you a real scenario and see how you respond, and then they will give you if your intervention right or no. How technology can help you to educate more and more people.
Yeah, I've done simulation training in a really nice lab, and we were doing ECMO patients, and so that was really nice to have the numbers pop up in the ECMO machine. It looked like real blood was flowing through. The vital signs were popping up. It was really nice. So that just helps it make it feel more real instead of me having to read out the vital signs. At least the first few simulations are very stop and go. Some scenarios, if you're looking at how to treat respiratory failure or hypoglycemia, I'm just trying to think of things that we used to do sims with, it's pretty cut and dry. So you can just push play and the mannequin can just say things, do things, you're seeing vital signs, and you just run through it. But this requires a little bit more stop, think. I ask questions and I open it up for people to answer, and then we push play. Stop, think. So, for example, what are the patient's risk factors for delirium? So here's the patient here for this reason. Here are their history. Here are their vital signs. Here's what's happened. Now we're in this moment. How are you going to manage them? What are you worried about? What are the risk factors for delirium? How will delirium impact their lives? So I'm trying to help them zoom in, zoom out, zoom
To
in,
connect the
zoom out.
theory and the practical together in a spot.
Yeah. So I think a Sims lab would be nice once they have more expertise and can just run through simulations a little bit smoother. But initially, I had to really hold their hands through the thought process. But I think there's always opportunity for technology. But a lot of this is so humanistic and it's so much critical thinking that it's still it can be very low tech.
Yeah, I believe there's a lot to do there and to make it high tech, and also to see the benefit from that and real scenario. And as I try to do on and off to connect the theory with the practical and to have that problem solving and judgment to know why and how. If I consider I have one hospital brand new, still, we need to open that hospital. So a typical hospital, what is your team and what their background and the number of those team, if you have the power to hire those team to start from 0 day to work on implementing the bundle?
So you want to talk staffing ratios?
No, I'm talking about if you have the power to implement that. So how many team member you need and what is their specialty?
I would have charge nurses that do not have patient assignments. That understand this bundle just like a Foley catheter. You know, if charge nurses are going around and around saying, do we need that Foley catheter? No, let's take it off. So a very protocolized, standardized way of looking at sedation and mobility. CNAs on the unit. So depending on the size of the unit, but CNAs that are not answering phones that are available to help. CNAs and or mobility techs that can either be on the unit or just be assistants to the PTs and OTs. And again, this isn't a dream world. Like not everyone has this and they're still doing this, right?
Yeah, this is the let's say the optimal scenario.
The optimal scenario, right? And I'm just even thinking about what we did, like what we had available to us. We had 16-bed ICU, and charge nurses usually did not take assignments. We had a CNA they were answering phones, but I would rather that they just be available to go into the rooms and help us. Some units don't have CNAs. PTs and OTs dedicated to the ICU, we didn't have that. We still shared them with the floor, but especially in bigger units, I think that they should be very well trained and specialized in critical care. A lot of times PTs and OTs are just told to go to the ICU, but they're not prepared for those kind of patients. They don't get to work with them until later. So I would want them dedicated to just being on the team so they have relationships with the team. They have a system, a protocol. They just have a routine rather than trying to scramble throughout the hospital. I want them fully there as part of the ICU team, which some ICUs do have, and it makes a huge difference. Respiratory therapists that don't have more than 4 or 5 vented patients. Ventilators that you can unplug from the wall and just transport, so you don't have to go and get a transport ventilator. Physicians that are always available, that don't leave for the night. You can do, intubations at night. I'm a huge fan, obviously, I'm very biased, but of APPs, so nurse practitioners that are very well trained in this, that have a lot of bedside RN experience. In a dream world, CNS. I'd never worked with a CNS before, but a clinical nurse specialist. But I just trained a team with a CNS, and that is an incredible role to provide high quality education, quality assurance with the nursing side of it. So in a dream world, that would be my kind of team. And speech therapists that are also trained for high level communication, not just for dysphagia. If we're like really getting fancy, recreational therapists, even just volunteers that will come in and play Uno with intubated patients, just to
This
entertain
helped
them.
me to understand how it is quite challenging to have all those to be set up. There's a lot of things is not only in the hospital and the leadership, beyond them, the system itself, it's built broken, and you try to a systematic change. So this is the question help me to understand the challenge if we need with zero patient to implement it. Something is not easy to implement it, but it's not hard. It's not impossible.
It's not impossible. Yeah, and
You've
I
been
think
in such a hospital, and you came from there.
yeah, and we continued it during COVID. So that was a very challenging time. And it wasn't perfect. And we did have travel nurses come in. We had nurses that left for the money. They left to be travel nurses. So we brought travel nurses in. Some of those nurses that left to be travel nurses came back because they were so mortified, traumatized by what they saw out there. Many of them didn't know what normal ICUs do. And so they went and they saw the harm that was happening. They were like, I have to go. So and I had the same experience, right? We want to be in a safe environment. We want to know that when we work hard, we're going to benefit our patients and see good outcomes. So I really think, and this isn't proven in the research yet, but I really feel like this is going to help with staff retention. When we learn and master team dynamics where you feel safe, you feel supported, you get to see good outcomes, you get to watch your patients that you've had deep connections with walk out the doors. And even if they don't survive, I think some of my end of life experiences there were some of my favorites. Having someone awake and be able to kiss their loved ones goodbye after extubation, being able to write their goodbyes, being able to tie up loose ends from work and their pension, just having an end of life experience with the patient involved rather than guessing what they want. The loved ones not being able to say goodbye or having to provide care that you think and suspect the patient didn't want. That all adds to burnout, moral injury, trauma for ICU nurses. So this process of care, my theory is, helps with staff retention. I worked with nurses that had been there for 25, 30 years. They were my mentors. And they just knew that they couldn't go anywhere else. They knew that. They never told me about it, but they knew that the rest of the system didn't do what they did there. And so they weren't willing to go and compromise their ethics and their standards elsewhere. And I still think that.
I left my practice in 2010, and now you remind me with all those in the ICU. All my experience was in the ICU. Now I feel I'm sorry for all the patient where they be sedated and the all pain they have and their family. And to be honest, I don't aware about this until I met you. Never ever hear about it at all. Then when I started to see you, what you are posting, and we started to connect and see this story, I feel why. And now when we get deep and deep with this podcast, just you give me that feeling. I feel sorry, and I hope.
And this is a really delicate thing to navigate. Yeah, I remember one of the first teams I trained, and it was. I started training teams in 2021, and this is one of the teams I think early 2022. I was trying to pick case studies that were relatable. This is before I had the idea of using their own case studies. So I used COVID patients because that was a patient population that everyone had treated. And that was a very powerful way to totally change outcomes. These patients ended up with a lot of sedation, a lot of these complications. And I just didn't realize how traumatic that would be. And some of the nurses went to their leaders and were like, they were in tears and they just were feeling bad. They're like, everything clicked. They realized the harm that they had done. And that was not my intention.
Yeah,
but we can't fix what we can't confront. So we have to talk about it straight. And I think that's partially why we haven't made much progress in the last few years, is because we've tried to be very tactful. We want everyone to feel good about their work. And I don't disagree with that. But also, they won't change it unless they understand the risks of it. So I have a little bit of a different approach where I'm like, if anyone's guilty, it's me. I came from an awake and walking ICU. I knew how to keep patients awake and mobile. I'd seen these things, but I went to a normal environment. And that is how powerful culture is. I was also a victim of knowledge. I didn't know why we did those things. I didn't know the harm of normal practices. I didn't know why sedation was dangerous. I thought patients were sleeping. So I'm just as guilty as anyone else. And so I've definitely felt those pricks of pain and guilt reflecting on things that I did. But we can't sit there. We have to use that to propel us into the future of, I will not do that anymore. Now I know, I didn't know then. We don't have to carry all of that guilt. That's not all on us. These are things that we have inherited throughout generations.
Yeah.
But we can use that to move forward with conviction that we know better and we will do better.
For sure, and you know the healthcare provider overall, they are suffering from compassion fatigue, and they felt they are powerless. But now you give us the hope. Something we thought is not in our hand. No, it is in our hand. We can improve. We can get better result, and we can make a systematic change, and we can see the result immediately. And you have proven this with the researches and also with the real success story where you bet with the patient and shooting them, recording them with their family. So a lot of good story to have been there. Now while we are talking, I was imagining and thinking how the technology maybe can help this to be implemented as a real bundle. So I came across, if we can implement this with the clinical decision support, like any drug interaction. When the physician go and put order, they will tell the system, listen, this medication, there is an interaction. Still, they can proceed with that, but they will put justification. Why not to have this bundle implemented and tell the doctor, listen, think about before give the sedation. There's a chance.
I think about it all the time because, yeah, if you go to order medication, the computer's already, there's an algorithm where it's looking at their kidney function, their things, and it'll pop up a warning saying, are you sure you want to order that or at that dose because their creatinine's X, Y, and Z? And when I see that, I'm like, yeah, that's what needs to happen every time you go to order sedation, saying, hey, they're 72 years old. They have a history of dementia. They're from a nursing home. Are you sure you want to order deliriogenic medications on them? I mean, so in my dream world, sedation's not part of the mechanical ventilation order sets. So I know from nurses, you don't always see what the providers see. But when we go to order mechanical ventilation, there's a whole order set, right? You're picking what kind of settings you want, what protocols you want to follow. And a lot of facilities, sedation is part of that. And a lot of times it's pre-checked. So they don't even have to go and select it. It's already selected for them. That all reaffirms like this culture of every patient is the same. Every patient will get sedation. My dream world is the sedation order set is a separate one. And when you go to order sedation, it's treated like an antibiotic, meaning that we as providers, we have to specify why we're ordering the antibiotic. Is it pneumonia? Is it urosepsis? For the antibiotic, for sedation, is their RAS +4? Are they having status epilepticus? We have to specify why, and there has to be an expiration date. So physical restraints expire every 24 hours. Sedation should too. So we have to reevaluate. Is there still an indication for it? Just to trigger us to go back and think, I don't want to add to the charting. I think we do not enough of that. But there needs to be some checks and balances, some triggers to make us critically think through these interventions that are so high risk.
So I want to share with you from my experience because I work in the health tech and I was abroad. If the hospital and my client not come for me and request this to be a features and to be like pop-up message or to have this functionality, we will not do it. So the hospital, they are not request this from us because the hospital, they are not adapt this. They are not consider that. So this is where the technology is not evolving because no pressure there. But when the hospital, hopefully soon, they will start to implement that, IT company, the health tech, they become under the pressure. They need to revisit their algorithm and the back end and see how to connect this integrated with the whole system. I want to end with you, Kelly, but I want to share also with you. Still, I feel with a strange feeling between I have that passion and see the future is there, and at the same time, I know it's not in my hand, but we try to not take it in our chest. But I feel sorry for my experience and the practice in the ICU, and you remind me with a lot of the old story. We had it day and night, and I hope this will be changed. And thank you for what you are doing, and I hope to have a lot of nursing like what you are doing, believe in what they are doing, and they are keep fighting years and years, and hopefully they will not struggle like you. But hopefully this will be changed. I feel more proud after this podcast. Every time I feel I'm proud, but I feel because I came from the ICU and I know the challenge which you are trying to do it and how you want to lead the whole clinician. I'm proud. I am your follow, and I am like you as a nurse. How I'm not doing what you are doing, but I feel in this situation. So you put me in very strange situation, and I hope through this podcast you will get more awareness and you will get more outreach from my network, and especially Arab country. I'm emphasis in Arab country. It is biased from where I came, because I believe our patient and our family, they need to treat very well. Kelly, how you want to end? I will leave it for you.
Well, and that's it's people like you that keep me going and also fill me with optimism for the future. Though obviously I am confronting very difficult topics, it can provoke a lot of defensiveness, a lot of guilt, a lot of anger. I've had nurses try to get me reported to the board of nursing. More commonly, though, I am reminded of how wonderful our clinicians are. That these are competent, smart, but most of all compassionate and caring people that want to do the best for patients. And a lot of the hesitation just comes from fear. They just want to protect patients. That's why the knowledge is so important, so we can help them guide their compassion in the right and most effective direction. And once that happens, it is amazing to see them take off. Some of the nurses that are the most hostile towards me, when I train these teams, it is so fun to watch them become the champions of this. When they see how good it is for patients, they become unstoppable. And that is what is so beautiful. And I think nurses especially are victims of this. Obviously, patients are victims. They suffer long-term disability and even death. Second to them might be families. And third to them are the nurses, because it is so much work, burden, trauma to see patients languish and suffer. And so one of the best outcomes I've seen, in addition to obviously patients surviving and thriving, is that the morale changes throughout these teams. When I go back and visit, their faces look different. Not just because they're not scowling at me anymore, but there's a light, there's a hope, there's an optimism, especially these teams that I trained during COVID that were so hesitant. They're like, oh my gosh, this is so much better. We're happier. We see success. They want to tell me all their stories. They're showering intubated patients. They're taking them outside. They get so creative, things that I didn't tell them. It just opens the doors for nurses to just run through and provide the kind of care and compassion and connection that they got into the field for. That's what keeps me going.
This is what you need to think about it and forget all those resistant and who try to stopping you because in any change there is a resistance will happen, and change is not easy. And think about all the positivity which you have, all the team who is encouraging you. I'm happy I am one of those team, and I see you in different way. You are the one who encouraging me, but thank you for that. And one thing to highlight it, Kelly, you in the LinkedIn you have more than K for the nurses following. So for the nurse like you, having such number in the follower in the LinkedIn, it is a huge. It's not easy. So you will not have that number unless you have a value you added. So I know who you are and what you are doing. This number is not an easy. You are authentic, genuine, try to do what you are doing. So you have a lot of followers and supporters and believer in you, and you have a good base of what you are doing. Maybe they are powerless, they are maybe afraid to advocate like what you are doing, but there's believer in your community and in your network, and the number is too big comparing with the nursing community, as I mentioned, especially in the LinkedIn. Most of the nurses, they are not in the LinkedIn. So what you are doing, it's great.
I felt really alone initially starting this in 2020. Just because God told me to start a podcast, I didn't know what a podcast was. I was just in my closet with this cheap little microphone, just like, hello? Is anybody out there? Just don't sedate them and get them up. Okay, bye. So I just didn't know what this would turn into, but it was very lonely initially. It was just like, it just felt like God and I were just bushwhacking our way through this. Now I do feel it's an international movement. It is a true revolution, and there are so many incredible people doing big to small things. Yes, I'm kind of the loud one online and kind of the face of it for now, but the reality is there are thousands of incredible people saving lives every day with this approach. And that's what I'm most proud of, is those revolutionists bringing this to the bedside and doing the hard things. And they face a lot of opposition within their teams. And yet that's even harder. I'd rather face online opposition than with my colleagues I have to see every day. And that's what these revolutionists do. And I could not be prouder.
Yeah, I agree. And this is the good story to share, and how you started. Nothing become easy, and you can see the evolve and the success down the road. And if you are not as successful, I will not came across your path, and we connect and started working together. Thank you, Kelly. I appreciate that, and I hope sometime bring you back with more success story and more mandated to implement the bundles.
Yep, when I have updates, let's circle back.
Sure. Thank you. Have a good day. Bye-bye.
Thanks, Manas. Bye.
If this episode sparked something in you, here's how you can keep our mission alive. Subscribe to Uncharted Narratives Certiat. Leave us a 5-star review. It helps more amazing people discover our stories. Share an episode that moved you with a colleague or friend. Connect with me on LinkedIn and join our healthcare innovation community. Together, we're not just telling stories. Until next time, stay curious, stay passionate, and keep pushing the boundaries of what's possible in healthcare. See you in the next episode of Uncharted Narratives Certiat.